when you have protein. Similarly, the fat content also to delay gastric emptying. The fiber content also, because no longer do we talk about soluble and insoluble fiber. Is it fermentable or not fermentable is way. So those have to come into the picture. But I would disagree about the role of probiotics. Probiotics should not be used in the intensive care unit at all. And there's a recent paper from the Journal of the American College of Surgeons that actually clearly states that when you give probiotics to anyone with a central line, the risk of colonization of the central line is so high that probiotics should be banned. We don't use probiotics, it's banned in all our pharmacies. This is mainly for the very sick, critically ill patients. Now, as far as the glucose control Sanjit, it goes on to show that we should never be the first to start anything and never be the last. There was such a huge hue and cry that occurred about 20 years ago that tight glycemic control is extremely important, except to show that the tight glycemic control actually increased the mortality. Therefore, from a very strict glucose control, everything was liberalized. At present, in a diabetic patient, we sometimes accept levels of 180 to 200. But in stress-induced hyperglycemia, we are a little bit stricter. The Aspen guidelines clearly that glucose levels more than 150. And at 150, you should start an insulin drip in the intensive care unit. Of course, some doctors may say 180, but the Aspen guidelines say that that we must initiate an insulin drip at that time. Now, the fact is, some folks may say, what about sub-Q insulin? Sub-Q insulin is not to be recommended in intensive care units, mainly because of circulation problems and the fluid in the subcutaneous tissue not absorbed very well, and then when the stress response is less and when the interstitial fluid is absorbed, suddenly you can have an upsurge of insulin that is absorbed and hypoglycemia. So it should be an insulin drip. Over.
Yeah. So we've gone from so many things, from the ACP guidelines to the SCCM guidelines to the ATA guidelines. So what I understand now from the best bottom line that we have is we will want not to have tight glycemic control. That means we don't want the sugars to be in the low 110s. Below that, we want the sugars to be somewhere around the 150, and we don't mind actually having a little bit of permissive hyperglycemia when it comes to specifically when it comes to diabetic patients. And this is a small trivia. What happens is this glycemic variability that we talk about is actually not causing much of a problem if you're diabetic. That's the diabetic paradox. I mean, that is something that is there in those patients who are sugar naive. That is where this glycemic variability makes a huge difference. Well, Dr. Sanghamitra, you did touch upon a few things that I wanted to delve on more intensively. So I'll probably go back to the same question that I came back to, and let's understand from you again once again.